Hello, welcome to this next session of IBD Essentials. My name is Raf Bisschops, and I'm here today with Professor Pradeep Bhandari, who is the current president of the BSG endoscopy section and who has a major interest in IBD endoscopy, Pradeep. And we will discuss some controversial things with him today. And I would like to invite the audience also to interact with us and leave some comments below this video. Especially to let us know what you think about the topics we're going to discuss. So what we're going to discuss is the recent BSG guideline on chromoendoscopy and what that exactly entails. And then we will go more to detection and management of colitis-associated neoplasia. So welcome, Pradeep. So it's a pleasure to have you here today, and you are a major expert in the field of IBD endoscopy with a long-standing experience. So and you've always been involved into the advancement in this field, and I think especially for the detection. So detection is very challenging. So I think many people were quite surprised, maybe a little bit disappointed last year when the BSG guideline came out and basically brought us back to base with chromoendoscopy. So what do you think about that, and what was the process behind that to come to that conclusion?
Thank you, Raf. It's a real pleasure for me to be with you this morning discussing some challenging and interesting aspects of endoscopy. Yes, IBD endoscopy is challenging. We started the journey with old-fashioned standard definition endoscopes, and dye spray came along. Evidence was very good. We all was doing dye spray. And then the endoscopes changed, high definition scopes, all the new technology, and data started coming, and we started replacing dye with virtual chromo or even high definition white light. And I also, like you, felt that this is the direction of travel. But when the guidelines were being done, they did a network meta-analysis, looked at all the published data, and found the overall, all the data was not very good. None of the data is good enough. However, when you compare high definition white light with dye spray versus only high definition, there is a small gain. You'll find few extra patients with dysplasia when you do that. When you compare all the other remaining technologies like AFI, NBI, BLI, full spectrum, all these, I think the data wasn't big enough to stand on its own. So I think the guidelines, if you read very carefully, to be fair, does say this is a very low grade recommendation.
I saw that, yes.
Yes, it's a very low grade because the data still is very poor. And it's just that the data for virtual chromo was not big enough to stand up in this. And also a recent meta-analysis then came out as well, which shows that dye spray also doesn't make any difference if you go for high-risk lesion like high-grade dysplasia. To me, practically looking at it, I think if you're using standard definition endoscope, which you shouldn't be using, then you definitely need dye spray.
Yes.
For sure. I don't think there's any debate. If you're using a high definition white light, I personally feel that it is up to your expertise, experience, and background of what will work best for you. High definition white light endoscopes have very high resolution. If the bowel prep is good, you can really see most of the things on white light, and then use your virtual chromo as you go along to enhance whatever you see. That works very well for a lot of people. I agree that the data is still not very good in randomized trial. We need more data there to justify. But virtual chromo, if you are not familiar with it, because the vessel patterns get distorted in an inflamed bowel, and that's the challenge with virtual chromo. So dye spray does work. I don't think there's any doubt about it, but it does come with challenges. Bowel prep has to be perfect.
So the basic idea is then that, okay, if you don't have that much experience and you didn't go through the learning curve of dye spray chromoendoscopy, that maybe you should not jump immediately to virtual chromoendoscopy, which is a little bit what we said in the ESG curriculum and the ESG guidelines. So,
Yes.
so is that then like an apparent contradiction between the BSG guideline, the ESG guideline, or are they still compatible?
I don't think it's a contradiction. I think overall, dye spray chromoendoscopy is more generalizable. Virtual chromo requires a lot more training and expertise.
Yeah, I wonder what the audience thinks about that, and maybe
Yeah.
you can let us know whether you use chromoendoscopy or virtual chromoendoscopy, or maybe you still use random non-targeted biopsies, 32 of those little biopsies in the colon. What do you think about that, Pradeep? Does that make any sense?
That I definitely believe is finished for all comers. But if a patient has PSC, patient has previous history of dysplasia, patient had biopsy which showed invisible dysplasia, which is very rare, in those patients, probably non-targeted segmental biopsies will help, but not in all patients. I don't think that's goal.
Okay, so I think you did very well as the president of the BSG endoscopy section to defend your own guideline here.
Sure.
So, but I think we can conclude it's still very challenging to detect. So, and recently you did some interesting work on detection with artificial intelligence of this these challenging lesions. I remember seeing some abstracts presented at meetings, and also one publication from Spain using basically CADI that was developed for colonic polyps for detection of neoplasia. And you see, is that enough, or should we approach this in a different way? What is your opinion on that, or should we be careful with those publications?
Yes, so very important. I think it's a very relevant question because now CADI for colonic polyps has been commercialized. It's everywhere, and there are 35 or 45 randomized trials showing that CADI in non-IBD colon improves your adenoma detection rate. We have done some work. Other groups have also done some work using this non-IBD CADI in IBD patients. And we clearly found that it does not work, it's not good enough. It does work because all CADI will detect polypoid lesion.
Exactly, yeah.
And polypoid lesion, you don't need AI. Every endoscopist will detect polypoid lesions. So if you do a study and your study population is predominantly consists of polypoid lesion, your CADI, any CADI will work. And that will misguide us. That's the danger here. So we did a proper study looking at a large sample of polypoid and non-polypoid lesions from IBD patients. And we found that standard CADI, which is not developed for IBD, had 100% sensitivity in detecting polypoid lesions. Okay. So if I just publish that data, it looks like CADI works.
Exactly.
You don't need a dedicated. But then look at the other subgroup in it with flat lesion, the sensitivity of this was only 60%. That's not good enough. And that's where we need help. So that's when we went ahead to develop a dedicated CADI system for IBD. Now that is challenging because the prevalence of these flat lesions in IBD these days is very low. So we had to collect a lot of lesions over many years to find a population to feed enough lesions to the system. So that's how we work, that we use the non-IBD neoplasia as well as IBD neoplasia and fed a lot of these flat lesions to it, and we found that it really works in IBD. And my thought process that time was, why not we use just this one for all colonoscopies? Why just for IBD? But unfortunately, again, it doesn't work like that because the background mucosa is different. Non-IBD background mucosa is different and IBD background mucosa is different. So this whole field is challenging, but to come back to the conclusion, I would, especially for our audience, I would really want to warn them that the standard commercial CADI out there does not work for detection of IBD neoplasia. Please do not rely on it. We have proven the concept that CADI for IBD can be developed. It is good. It does work. However, there are still challenges. And the challenge is it detects every possible lesion in the colon.
Yeah.
And there are more non-dysplastic lesions in an IBD colon than dysplastic
But
lesions.
is that such a bad thing? Because if you look at all the imaging studies you referred to earlier, the neoplasia detection rate per biopsy there, which are targeted biopsies, is only around 20% at best. So
Yes.
so maybe we can replace the chromoendoscopy with something like that in the future, no?
I 100% agree. I think this is where the beauty of AI is. AI works on simple white light. No need for enhancement. You need good bowel prep, and you need a good endoscopist who can do a decent colonoscopy. The good thing with colitic bowel is generally the bowel is lax folds,
Yes.
lax loops. It's generally a straight bowel. So you don't need a huge expertise in doing colonoscopy and exposing the mucosa because the colitic bowel does that for you. So I think to me, the other way to look at it, Raf, is CADI has been has been around now for more than 5 years, a lot of data. But when you talk to the industry, they still feel that the endoscopists are not investing, they're not buying, they're not using the CADI because they feel they don't need it.
Maybe it's too expensive too.
It is expensive, and it is only detecting diminutive polyps. And so endoscopists feel it's not worth my time or money. But when it comes to IBD, and when this data comes out to show that how it can change your practice completely from virtual chromo or dye spray, like in England now everybody is doing dye spray, that's cumbersome.
Absolutely, yeah.
That takes a lot of time, money, effort, learning curve. You can replace all that with AI and white light. And I think that's the time when endoscopy world will engage with AI properly, because it simplifies our life and patient outcome. Certainly.
Excellent. So you seem very passionate about this topic, Pradeep. So can you explain to the audience how your passion was triggered for this particular topic in endoscopy? I mean, IBD is really a niche. So why were you so interested in endoscopy and IBD?
I think for me, if there is a challenge, I just feel I need to rise up to it. I started my journey with polyps, with Barrett's. You know, in UK, we got plenty of Barrett's, and detecting neoplasia in Barrett's was always challenging. So we found a way with acetic acid, and that worked really well. And that was very satisfying to see things that we were not able to see with acetic acid, we were able to see. And then only when you can see properly that you can resect, because I love to resect lesions, not to detect. But I cannot resect if I cannot detect.
Okay.
So this is the whole thing. So when we moved on slowly from Barrett's to standard colon, IBD is way down the line. This is the most challenging part of the work that people like you and me do. Detection as well as resection. So this is where I felt that an endoscopist really needs help with AI, because Barrett's neoplasia, IBD neoplasia are very challenging. In Barrett's, we only have about 5, 10, 12 centimeter of mucosa to inspect. In IBD, you have the whole colon.
Exactly.
So it's a massive challenge, and I honestly believe this is where AI will make a big impact in our working pattern. So that's why we put in a lot of effort, and when you see the results, it's always very rewarding. I wish I'd patented all these things. I would have also had financial reward, but just I have no financial reward there. It's pure science.
So you have to start off with the intelligent satisfaction here. So no, okay. So this brings us to the next topic. You talked already about resection. So management of these lesions when they are found can also be quite challenging. So I wonder also how the audience thinks about management. Do they all need a colectomy? Should we be very conservative? Can we do partial colectomies in patients with long-standing colitis? So can you explain us a little bit how you do in Portsmouth your MDTs when you find a lesion, how you decide on a patient that needs a total colectomy, a patient that needs EMR, ESD, or a patient that even may need a partial colectomy, or don't you do that? How do you go about
No,
these
it's
things?
a very, very important point. But before I move on to that point, I also want to tell the audience to put their comments and tell us about the role of AI in endoscopy, or where they're using AI, and if they agree or disagree with me in terms of AI in IBD. It would be very interesting to know what our audience thinks about it. So managing these complex lesions in IBD is a real challenge. And I think we practice, and a lot of centers practice, and I think most guidelines would also suggest that you should not willy-nilly resect a lesion when you're doing an IBD colonoscopy. I think these small lesions are absolutely fine to resect, because anything less than 10 millimeter or a polypoid lesion is not dissimilar from a non-IBD colon, and we should be able to resect. But whenever there's a larger lesion or a flat lesion, I think we need to be very careful, because there's only one chance to get it right. If you're going to do endoscopically, it has to be done properly. If you don't do it properly, either we have a complication or we have a recurrence. So to me, the way we look at it's a flat lesion, then all flat lesions we discuss in IBD MDT. We have very good quality images. If possible, a video is fantastic, but you can't always get a video. But at least you can get good white light and enhanced images to look at. And based on that, you can decide about endoscopic feasibility of resecting it. Second is looking at the rest of the colon, or what else is in the colon. And third, the course of the disease. If patients are constantly having flare-up, disease has always been active in the last 2-3 colons, all these things will play a role in how we manage. I'm an endoscopist. I love to resect lesions, but we need to be really, really careful here, because there are a lot of challenges. First is there is fibrosis, so they don't lift very well. Second, if patient has had a lot of inflammation, flare-ups and healing, they develop a lot of fat in the submucosa. So if you want to do ESD, that fat is very, very challenging. And within the fat comes the vessels. So that poses another challenge. And then finally, we need to know what else, where are the other lesions?
And what the patient wants, obviously, right?
Before we go there, I absolutely agree. In the MDT, very clever people sit and we come up with a conclusion that, no, I can do endoscopic resection, let's do. When you go and talk to the patient doesn't want to go through an intensive surveillance program. Because if I take on a large lesion to resect an IBD colon, I'm taking on intensive surveillance for at least 5 years.
Exactly.
Patient has to agree to that. He needs to come to that. I need to have a capacity in my department, in my work pattern to deliver on that. So I think we need to consider all these things when we make a decision. Of course, surgeons in the past always used to believe neoplasia in IBD is a field cancerization. If you get dysplasia, you're going to get cancer and everybody's colon should be out. I think surgeons have moved away from that. Endoscopists, enthusiastic like me, who want to just resect everything, also need to think carefully. I think balance is somewhere in between.
Okay. So certainly not one size fits all. So, okay.
Definitely.
Thanks so much. So before we wrap up, you're very passionate about this topic, but maybe the audience also wants to find out 1 or 2 things you're passionate about outside of endoscopy and IBD. Can you tell us?
Well, I have passion for a lot of things. Unfortunately, for me, endoscopy is a sport. I play this sport on every day. I get all my adrenaline surge with endoscopy. So when I go home, there's not much of adrenaline left in me. So I love watching football matches. I love watching cricket. I used to play a lot of cricket, but unfortunately haven't practiced, so no good for cricket. So I now watch cricket. I watch football. I love films. I watch a lot of movies.
And who do you support then, India or the UK?
Oh, that's a difficult question. I would not like to answer online.
Okay, so thank you very much, Pradeep, for this IBD Essential episode. So if you like this session, please like it and also follow us for further future episodes. Thanks for watching.
I would like to say the same, and we would really be interested in your comments to say where you agree with us, where you disagree, because then we can come back to you with another episode answering all the questions you have in your mind.